Good day. This is the editor's podcast for the Journal of the Academy of Nutrition and Dietetics. I am Dr. Linda Snetselaar, editor-in-chief of the journal. And with me today, I have Dr. Lisa Moloney, who is also an RDN, and she is currently a nutrition researcher at the Academy of Nutrition and Dietetics. She's also the first author of a manuscript on the topic of validity of predictive energy expenditure equations compared to indirect calorimetry for hospitalized adults, an evidence analysis library scoping review. Welcome, Dr. Moloney.
Thank you for having me.
So my first question is, would you explain for us what a scoping review is, and then why it was the right approach for this particular topic?
Yeah, absolutely. So the first thing I think I should start off with is comparing a scoping review to a systematic review, because I think these two are often confused with one another. A systematic review answers a very specific PICO question. Systematic review questions are much narrower. They follow the PICO question format, so it's population, intervention, comparator, and outcomes. Systematic reviews include evaluation of the risk of bias of all of the included studies. It includes synthesis of the studies that meet the criteria. They may also include meta-analysis or narrative synthesis, and it answers the PICO question generally with a 2 to 3 sentence conclusion statement, and you have the certainty of available evidence. Where scoping reviews are generally much broader. We don't limit by outcomes. So scoping reviews follow the PCC mnemonic. So we're limiting our studies to population, concept, and context. We generally don't limit by outcomes. And scoping reviews also don't include that risk of bias or meta-analysis or narrative synthesis. Instead, we're mapping the available evidence. We're getting an idea of what the evidence is out there for our topic of interest. So at the Evidence Analysis Center at the Academy, we generally start our projects with a scoping review before committing resources to a systematic review with a real narrow question. So scoping reviews are generally used for topics that might not have been comprehensively reviewed yet. Maybe they're helping guide a research agenda for maybe a new topic, or they can also be used for topics that might be really complex and heterogeneous. So that's where our predictive equations come in. This is a topic that can be extremely complex. The populations can be extremely heterogeneous, as well as the predictive equations used. So we started with the scoping review to map the available evidence, and that would help guide our future research for systematic reviews and set parameters for those systematic reviews. So we don't start off with a systematic review question that's too broad to answer or too narrow that didn't have any available evidence. Scoping reviews can also highlight any research gaps to help guide future primary research. So as I mentioned, we're using the scoping review as a precursor for systematic reviews, and then those systematic reviews go even one step further to develop evidence-based nutrition practice recommendations. We also want to identify which predictive equations had enough evidence to be candidates for a systematic review. We want to determine if there were if there was existing literature on subpopulations. So we looked at hospitalized adults. We want to know if there was any subpopulations where we can provide, more precise recommendations on equations that should be used for those subpopulations. So individuals with specific diseases or conditions. So for example, is one equation better for adults with chronic kidney disease or adults with obesity and critical illness? We want to know how deep we can go or how specific we can go with those systematic reviews. We also wanted to learn what evidence has already been synthesized. So if there's a really great systematic review out there that's high quality, it's been published within the last couple of years, it's answering a question of that would be of interest to our practitioners that are using our evidence-based nutrition practice guidelines, there's no need for us to recreate a systematic review if we've identified one that's out there. So that's a big purpose of a scoping review as well. We open it up to primary research as well as secondary research. So we know that, all right, there's no systematic reviews out here. We need to proceed with an SR, or here's a systematic review. This is great. We can jump right to guideline development. We also had a secondary objective. So the first part it was more so confining and determining the parameters for systematic reviews and future research. Our second one was a little bit more exploratory. We wanted to determine if there was any evidence out there that compared nutrition support guided by indirect calorimetry to nutrition support guided by predictive equations and looked at the impact on outcomes. So we wanted to know, okay, great. So you're using this predictive equation. Is there going to be any changes on ICU length of stay or hospital mortality? What kind of impact is this making by choosing which equations, or is indirect calorimetry improving outcomes if that's guiding nutrition support? So that's one area that we really weren't sure if there was available evidence. So as you can see, this topic is incredibly broad. So we wanted to set parameters for systematic reviews and identify the gaps and determine if there was a reasonable amount of evidence to pursue systematic reviews for indirect calorimetry compared to predictive equations guiding nutrition support.
Thank you. So very helpful. And I think most of what you were saying in the past few minutes gives us a wonderful way of looking at what the Academy does in terms of research and looking at the evidence that's out there. So thank you so much for that. My second question then is, what did you find when you were looking at how much evidence is actually out there? And were there any surprising gaps?
Yeah, absolutely. So I generally go into these scoping reviews or systematic reviews and thinking that you have a pretty good grasp on the available evidence or what we anticipate in finding, but there's always a lot of surprises. So first of all, we had 152 studies included in our scoping review. So I mean, I knew it was going to be pretty big, but it was bigger than I anticipated. We had 147 primary studies, and we only identified 4 systematic reviews. So I was a little bit surprised on the systematic review part. Only 4 was much smaller than I thought. We did have some information on the subpopulations I mentioned earlier. So majority were for adults with critical illness, so not a big surprise. There was some subpopulation analysis for individuals with brain and head injury or the older adult populations. Unfortunately, we found a lot of heterogeneity within those subpopulations. So for example, we had a lot of studies that maybe looked at the older adult population, but they were all using different predictive equations, which can make synthesis down the road a little bit difficult. And then the biggest surprise was the amount of predictive equations. I couldn't believe it. So there was over 65 predictive equations that had evidence on the validity of those equations for hospitalized adults. So I knew there were going to be a lot. 65 was definitely not in my crystal ball. We did have the most available evidence was for the Harris-Benedict equation, so not too surprising there, just considering the historical precedent and familiarity with HBE. And then we also wanted to determine too, so this one we weren't too sure about. So indirect calorimetry has been identified as the gold standard for quite some time on the best method to evaluate energy needs of hospitalized adults. And because it's been the gold standard for quite some time, I really wasn't sure how much recent evidence we were going to have on evaluating, how valid these equations are. But it's still a pretty hot topic. We found over 47 studies that have been published within the past 5 years. So what that is saying to us is that there's still some major barriers to using indirect calorimetry in the hospitals, but we don't quite know. I mean, we have an idea, some guesses about what those barriers are, but not something that's been broadly investigated. We also find the reporting was a little bit inconsistent in the studies. So sometimes we didn't have information on what weights were used. So for example, in an equation where the author is using the actual body weight, the ideal body weight, sometimes that just wasn't reported, unfortunately, and as well as stress factors. Like there was a good chunk that did report these, but we did have a lot of missing data on if a stress factor was used and what that number really was. There was also a lot of heterogeneity in the outcomes that were reported, so not the typical outcomes you would expect to see in a study evaluating validity. Granted, we did have a good bit, but I was surprised with how many studies that didn't have those expected outcomes for those types of studies. And our biggest gap is, so I did say this was exploratory, but what studies are really evaluating the impact of nutrition support on outcomes that are guided by indirect calorimetry or the predictive equations? We only found 9 studies. So while it's great that if we determine, X, Y, or Z equation has the best validity, we don't know if use of that equation is going to improve patient outcomes. We only found 9 studies. So that was definitely a gap where we need some further primary research.
very informative in what is out there in terms of the evidence. I think that this scoping review really sets the stage for future systematic reviews and then ultimately clinical practice guidelines. What should RDNs be watching for? And are there any things that you might tell them in terms of takeaway messages right now?
Yeah, absolutely. So we do have systematic reviews currently in progress for predictive equations. While our scoping review was for all hospitalized adults, we narrowed it down to adults with critical illness in the ICU. So as I said before, these scoping reviews helps us set parameters to make the systematic reviews more manageable. So a systematic review with 152 studies would be quite difficult. So we narrowed it down to those with critical illness. This systematic review will include meta-analysis on some of your commonly used predictive equations, and then those systematic reviews will be used to develop evidence-based nutrition practice guidelines or nutrition practice recommendations. And those recommendations will be part of a broader guideline that also includes nutrition support recommendations. So we've been kind of working on these two projects in parallel, the assessment component as well as the intervention component. So I should also mention, we also have an umbrella review available in JAN. And by umbrella review, I mean it's an investigation of the available systematic reviews and guidelines for nutrition support interventions. So we use that data to develop guidelines for our intervention component while we're using the scoping review data to guide our systematic review for the assessment component. So you can expect to see one, systematic reviews for predictive equations, and two, a guideline that includes assessment recommendations as well as intervention recommendations. As far as the key takeaways for practice right now, I mentioned in the beginning that we don't answer the question like which equation is most valid. But what we did determine is that, due to the amount of heterogeneity and practical feasibility that comes with indirect calorimetry, clinicians really need to balance clinical accuracy with practical feasibility. If indirect calorimetry is not feasible in your setting, it's perfectly okay to pursue use of these predictive equations, but we have to interpret the predictive equations with caution. We never solely want to focus on that initial estimate. It's really important to have that ongoing monitoring, and reassessment is really essential. Using your clinical judgment is always a critical factor. Equations are the tool and not always the perfect answer. So I guess the key takeaway is that yes, these predictive equations are great. They're, a great tool for dietitians right now, but, use your clinical judgment, and ongoing monitoring, reassessment, and individualized care definitely takes precedent.
Thank you. Great advice. I so appreciate your being with us today and want to say that I think you've provided a great deal of information in terms of the ongoing work that the Academy does in terms of providing clinical dietitians with additional information on what they might be doing in their clinical practices. So thank you so much for that. I also feel very positive about the fact that you were focusing in this work on hospitalized patients. And I think that's an important group to highlight. So I'm hoping everyone goes to your article to read more about what your findings were. And thank you so much for all of the work that you've done to move this area forward in terms of predictive energy expenditure equations. Thank you so much.
Yeah, thank you so much for having me.
Thank you for listening to our discussion today. Additional scholarly articles related to today's topic are available on our website at www.jandonline.org. If you found this discussion informative, please like and subscribe for more content. Thank you for your time and support.